Multiple myeloma is a plasma cell neoplasm. To explain this, we have to take a look at hematopoesis. Initially, stem cell is differentiated into the common lymphoid progenitor cell, then into the lymphoblast, then into the prolymphocyte, then into the small lymphocyte, and then into the B lymphocyte, and the activated B lymphocyte in the blood called plasma cell. In normal condition, the function of the plasma cells is antibodies production. Another name for antibodies is immunoglobulins, so it's the same thing. The most common immunoglobulins are immunoglobulin G, M, and A. And exactly malignant clonal proliferation and accumulation of plasma cells, called multiple myeloma. Because plasma cells are the most mature cells in lymphopoiesis, multiple myeloma belongs to chronic lymphoproliferative disorders. And as practically all chronic lymphoproliferative disorders, multiple myeloma most commonly affects adults. So how multiple myeloma develops? Recall that in lymphopoiesis, initially in the bone marrow, stem cells undergo differentiation into the lymphoblast. Some of the lymphoblasts remain in the bone marrow, where they undergo differentiation into the B lymphocytes. Let's call them B cells. These B cells are naive, they do not produce any specific antibodies yet. Then these naive B cells enter into the blood, where they circulate in the resting state until they will meet antigen. And when antigen stimulation occurs, let's suppose by Staphylococcus aureus, the minority of them begin to fight straight away. They begin to produce the default low-affinity immunoglobulin M antibodies. But the majority of naive B cells migrate into the peripheral lymph nodes, where in the germinal centers they undergo class switching and somatic hypermutations. As a result, mature B cells are produced. Basically, these two processes allow B cells to produce the most effective type of immunoglobulin with the highest affinity against a certain bacteria, in our case against Staphylococcus aureus. The problem is that class switching and somatic hypermutations occur at a very high speed, and the more rapidly process occurs, the higher the chance of mistake. In our case, the higher the chance of mutation. And because of that, during class switching and somatic hypermutations, a lot of B cells are produced broken, with inability to produce effective antibodies. Recall that antibodies consist of 2 light chains and 2 heavy chains, and during class switching and somatic hypermutations, some plasma cells produce broken. Such broken plasma cells can produce just antibodies with only light chains, for example. And obviously such antibody cannot help to kill the bacteria. Usually such broken B cells immediately activate apoptosis and die in a process called negative selection. So in normal condition, broken B cells prefer to die nobly through activation of apoptosis, and by this they prevent a catastrophe. And in normal condition, survive only the plasma cells that can produce perfect, high-affinity normal antibodies. And when B cell leaves the germinal center, in the blood such cell become plasma cell. In our case, this plasma cell will produce immunoglobulin G antibodies against Staphylococcus aureus. Now what happens in multiple myeloma? Initially, mutation during class switching and somatic hypermutations occur. In multiple myeloma, it can be translocation between chromosome 6 and 14 that cause overexpression of interferon regulatory factor 4. To explain the logic of this mutation, we have to know that on chromosome 14 located immunoglobulin heavy chain locus. And because naturally the major function of the B lymphocytes is antibodies production, and antibodies composed of light chains and heavy chains, the region that is responsible for heavy chains production in B cells is highly active, it almost always on. And on chromosome 6 located gene that encodes interferon regulatory factor 4. Interferon regulatory factor 4 is a protein that regulates cellular proliferation and growth. But the major feature is that IRF4 inhibits cellular apoptosis. In normal condition, in most cases, gene that is responsible for production of IRF4 remains inactive, and in case of B cells are produced broken, this permits broken B cells that had failed to produce high-affinity antibodies to quickly activate apoptosis and die in a negative selection. But with translocation of immunoglobulin heavy chain gene, to interferon regulatory factor 4 gene, now this highly active gene stimulates interferon regulatory factor 4 gene, or we can say it causes overexpression of IRF4 gene, and in response to this, cells significantly increase the production of interferon regulatory factor 4 protein that in turn inhibits cell apoptosis. So overexpression of IRF4 causes inhibition of apoptosis, and basically this results in production of immortalized cell. Now there are two possibilities. If such mutation occurs to a B cell that is unable to produce normal antibodies, normally such cell will activate apoptosis and die in a negative selection. But in this case, overexpression of interferon regulatory factor markedly inhibits apoptosis and forces this B cell to live. And now we have immortalized B cell that produce broken immunoglobulins. And then this broken B cell enters into the blood and become plasma cell that can produce only immunoglobulin light chains. The second possibility, if such mutation occurs to a B cell that is capable to produce functional antibodies, in our case against Staphylococcus aureus. So now this immortal B cell enters into the blood and become immortal plasma cell that produce immunoglobulin G against Staphylococcus aureus. And after a relatively short period of time, plasma cells are going into the bone marrow, where every plasma cell grows in its own bone marrow niche, and from the bone marrow, plasma cells secrete their own antibodies. The major problem for immune system is that mutated plasma cells cannot change the type of immunoglobulin that they produce. Moreover, they cannot modify this immunoglobulin against any other bacteria or virus. So they are perpetually doomed to produce just broken immunoglobulins with only light chains, or to produce only immunoglobulin G against, in our case, Staphylococcus aureus. And because all immunoglobulins that malignant plasma cells produce just the copies of each other, such immunoglobulins called monoclonal immunoglobulins. The problem here is that with time, in normal condition, every cell has to die of old age, and self-elimination of plasma cells occurs by apoptosis. But with anti-apoptotic mutation, apoptosis is inhibited, so now we have immortalized plasma cells in the bone marrow. Because mutated plasma cells live much longer than normal plasma cells, their proliferative rate prevails over the death rate, so with time they slowly but steadily accumulate. And at the same time they continue to produce monoclonal antibodies. And the presence of less than 10% of immortalized clonal plasma cells in the bone marrow that produce less than 3 grams per deciliter of monoclonal immunoglobulins, called monoclonal gammopathy of unknown significance. So in monoclonal gammopathy of unknown significance, because there are only a few clonal plasma cells, we have just small increase in production of monoclonal immunoglobulins. And because on protein electrophoresis, immunoglobulins classify as gamma globulins, this condition called monoclonal gammopathy, and this elevation in gamma globulins called M spike. M stands for monoclonal. And with time, while plasma cells remain in the bone marrow, the second mutation can occur. Let's suppose that translocation between chromosome 8 and 14 occurs that results in overexpression of c-Myc protein. c-Myc protein activates expression of many pro-proliferative genes. For example, it drives cellular proliferation, stimulates cellular growth, and inhibits cell apoptosis. So actually the second mutation just amplifies the effect of the first mutation, and now such broken plasma cells become even stronger. Basically they are practically immortalized cells with very high proliferation rate. So because the second mutation makes them even less prone to apoptosis and also significantly increase their proliferation capacity, with time the number of malignant plasma cells progressively increase. And after some period of time, the amount of plasma cells become greater than 10% of all cells in the bone marrow. With increase in quantity, their monoclonal immunoglobulin production capacity increase, and now they produce greater than 3 grams per deciliter of monoclonal immunoglobulin, and such condition called Smolderin multiple myeloma. So initially from monoclonal gammopathy of unknown significance, disorder progressed to Smolderin multiple myeloma. So the major problem is that these two mutations make mutated plasma cells practically immortal, and in addition to this, they have very high proliferative rate. So obviously with time the quantity of mutated plasma cells will inevitably increase. But usually, to accelerate the process, the third mutation is required. For example, it can be deletion in the short arm of chromosome 17 that disrupts the function of p53 protein that basically gives green light for oncogenesis. And when the third mutation is added, it amplifies the effect of previous two mutations and makes clonal plasma cells even more aggressive. So the amount of plasma cells in the bone marrow increases even further. The higher the quantity of mutated plasma cells, the higher becomes the production of monoclonal immunoglobulin, so the more severe will become the clinical picture, and with time so-called myeloma crab features develop. Immunoglobulins in high quantity cause severe kidney injury that will manifest with increase in creatinine level and also with decrease in erythropoietin production. And decrease in erythropoietin production will cause decrease in red blood cells and hemoglobin concentration in the blood, a condition known as anemia. In addition to immunoglobulins, also plasma cells produce RUNCL molecules that act on osteoclasts and stimulate osteoclast proliferation and activity. And as we know, osteoclasts destroy bone tissue, thereby they wash out calcium from the bone tissue into the blood. And the crab features are exactly bone injury, hypercalcemia, renal injury, and anemia. At a stage of monoclonal gammopathy of unknown significance and Smolderin myeloma, the amount of mutated plasma cells and their secretion capacity is too small to produce sufficient amount of RUNCL or immunoglobulins that will significantly affect the state of the bone and kidney tissues. But with time, when the third mutation is added, and the amount of clonal plasma cells in the bone marrow reach significant number, they begin to produce significant amount of RUNCL and immunoglobulins to cause significant bone tissue destruction or kidney injury that will manifest as crab criteria. And the condition that is characterized by the presence of at least one of the crab criteria, together with amount of plasma cells greater than 10% of all cells in the bone marrow, and the concentration of monoclonal immunoglobulin in the blood greater than 3 grams per deciliter, called symptomatic multiple myeloma. Now, in 80% of multiple myeloma cases, plasma cells produce monoclonal immunoglobulin with normal structure, and only in 20% of cases, plasma cells produce just light chains of immunoglobulin. And this type of multiple myeloma called light chain multiple myeloma, also called Bence-Jones myeloma. And Bence-Jones myeloma has much worse prognosis, and in pathogenesis we will see why. If you like content, please press like and subscribe button. All the best!